that. My personal approach, again, would be to look for the things that are most easily reversible without causing any harm to the patient.
I guess, Dr. Zachary, one of the issues that we have is, as Janet says, we're the nurses and we see this. You know, they've already done their history physical, they've come up, and we can tell that there's something. So it's that catch-22 of trying to get the doctors to understand that this is what I've seen, this is what's going on, and then they switch doctors on us, and then gotta go back and do. And what happens to some of our patients is it's just like a yo-yo back and forth upstairs. You know,
is upstairs.
Medical.
Oh, okay, okay.
So we'll send them up. They say, well, let's just hydrate them. We'll send them up for 24 hours. They go upstairs, get hydrated. Then they want to send them back. They come back. They decompensate. You know, it's just, and then we're going back upstairs.
And that requires a lot of education of the physicians as well. You know, because delirium, if you come in because you're dehydrated, and you know, you described a dramatic scenario where they get fluids and all of a sudden get better. More times than not, it actually takes a few days, right? And in that period of time, you know, you may have to hang out in the hospital for a little bit, unless somebody gets their hands on you and starts ordering all kinds of crazy tests.
And then we move the person back and forth to different environments and they get disoriented.
Absolutely, and actually, so we'll talk a little about the causes of delirium. And this is, I'm going to skip really quickly through this very simple slide. As with all geriatric syndromes, the cause is there are many, and there are too many to count. We'll talk a little bit about what the risk factors are. So just like you were saying, where's dehydration? Dehydration, we talked about changing, I know I have this in here, changing your environment, huge. There is some musical beds that occurs in hospitals that is beyond me. And when I say it's beyond me, I'm not sitting in judgment. I say I really don't understand, but there's got to be a reason why. Oh, this isn't a male bed anymore, it's a female bed. We have to switch them. Even switching from, coming into the hospital is a change of environment. Switching from room to room within the hospital, another change of environment. You're changing nurses, you're changing physicians, shift changes. Certainly don't expect the nurses to stay 24 hours a day. Certainly don't expect the doctors to work 7 days a week. You know, things change. That's very scary. That's the reason why the hospital is a really kind of dangerous place for these patients. By virtue of being a geriatrician, I can tell you the biggest risk factor for delirium is just being elderly. And it's actually the youngest young and the oldest old are the greatest risk for delirium. Drugs, we talked about withdrawal from drugs, being on too many drugs, or side effects of the drugs. Underlying dementia. I want to say, I think it's, if you have dementia, yes, I'm going to say this right. If you have dementia, you have a 5-fold risk of becoming delirious. And in delirious, when you're in the hospital. Delirious patients in the hospital, older delirious patients, you'll find that about 1/3 of them already have dementia. Some people argue that you cannot have delirium unless you already have cognitive impairment. And the idea is, even in the young, well, the youngest, these little babies, are they demented? No, but their brains aren't fully formed, and so the thought is that because they're sort of not, regularly active, productive members of society, that they're at increased risk for delirium. We talked about impaired mobility, using restraints, how those speed up the process of homeostasis. They also are risk factors for delirium. Most geriatric syndromes, for example, falls, which can be considered a geriatric syndrome. Once you fall, you're always at a greater risk for fall. Once you've had an episode of delirium, you're always at a greater risk for episode of delirium. It's kind of depressing. I want to point this out. Constipation. Constipation can cause delirium. People don't believe that. Can you think about when you have to go to the bathroom? Can you think about anything else? No. You have to go to the bathroom, I have to go to the bathroom, I have to go to the bathroom. If you couldn't concentrate, of course you get delirious. Impaired ADLs, activities of daily living. The way that I teach this to the residents is there are 6 activities of daily living, and they're the things you do when you wake up in the morning. So you get out of bed, that's transfers. You go to the bathroom, that's toileting and continence. You wash yourself, that's bathing. You feed yourself, and you dress yourself. So those are the 6 things you do in the morning. The reason why these particular ADLs are I'm going to put so much importance in them, is they're called the CATS, or KATZ ADLs, is that studies have shown over time that if you are missing one ADL, if there's one ADL that you cannot do, you are at, your life expectancy goes down by about 6 years, and you are at a grave increased risk of institutionalization. So any impairment in your ADLs, you're at really big risk for delirium. So if there are 2 things you take away today, number 1 would be, please remember what your risk factors are for delirium. So when these patients hit your floors, your patients are already going to be at risk for delirium, but let's say you have an older patient on a lot of drugs who doesn't walk very well, impaired ADLs, they're up there. They're up there. They're probably going to get delirious. So how do you diagnose it? It's hard to say whose job this sort of is, but anyone who can take it upon themselves to recognize people who are delirious would be helpful. It's not necessarily, it's again one of those hot potatoes. Well, it's not my job, it's the nurse's job. It's not the nurse's job, it's the doctor's job.
We're really lucky that Dr. Blaustein has a geriatric specialty because he's wonderful at
Right, and right, he, I've spoken with him at length about it before. No, that's great. So one thing that's really important is you have to determine what the patient's like normally. So, you know, maybe they always are a little hypomanic, and that's okay. But if they're not normally hypomanic, then that's a change in their cognitive status. Cognitive assessments, like the mini mental status exam, there are shorter tests that you can do. For instance, if you want to test attention, you can ask patients to say their phone number forwards and backwards, or say the months of the year forwards and backwards, and that's a pretty, you know, a pretty quick test. There are other fun ones like naming as many animals as you can name in a minute. And if you can name 8, then you're not cognitively impaired. And they have to be animals and you can't repeat them. But something that I've actually been working with our ICU nurses on doing is something called the acute confusion assessment method. And I would actually recommend that, I should have brought you in, I'm sorry, I should have brought you in an extra copy, but I would recommend that you just Google it. Go to confusion assessment method, or Bing it, or whatever you do, and look this up. So remember, there were the 4 qualifications of defining delirium: acute onset, change in cognitive behavior associated with the comorbidity, and what did I say? I'm sorry, what did I say? I said acute onset, I'm delirious. Poor attention, change in level of consciousness, cognitive impairment, and associated with the medical comorbidity. Did I say all 4 of them? Mm-hmm. Okay. So you're going to take that into account when you're doing the CAM. So number 1 is you see is the delirium of acute, or the change of acute onset. You have to ask the family members or the caretakers if that's true. Number 2, are they having inattention? Are they having a change in their level of consciousness? Are they either too hyper or too hypoactive to participate? These 2 have to be present, okay? These 2 features have to be present. And then either 3 or 4. So disorganized thinking, hallucinations, not being able to sort of carry on normal conversation, altered level of consciousness, again, being too hyperactive or hypoactive. So for some reason, when we first rolled this out in our ICU, it was very confusing. And I'm pretty conservative, I guess you could say. I don't like change either, and nobody likes to have more work. So I think when we first rolled this out, people were very confused. But I'll just give you an example of how easy it is. So you 2 know each other, right? Mm-hmm. What's your name? Deanne. Deanne? Deanna. Okay, nice to meet you. So Deanna, you know Terry. What is Terry's normal sort of, is she awake, alert? What's her normal level of consciousness? Okay. Is she usually pretty attentive? Okay, so she's automatically not delirious because she doesn't meet feature number 2. All right, you have to have 1 and 2, and then either 3 or 4. Okay, Cam, done. Not delirious.
So
does that make sense? Yeah, Terry.
The number 3 and 4 we see in our psych patients too, you know.
Right.
So, but they have to have the first 2.
But they have to have the first 2, and this is probably what will differentiate a lot of your psych patients from the other ones, is the acute onset.